Dear audience, my PhD thesis is investigating the cardiac complications associated with acute pancreatitis. I'm a second-year internal medicine resident at the Hospital of Székesfehérvár, and my vision is to decrease the mortality of acute pancreatitis by foregoing the preventable complications. My mission is to conduct high-quality research to understand the effect of acute pancreatitis on the cardiac status. I have 3 ongoing projects. The first is done by the methodology of systematic review and meta-analysis, and the second and the third are protocol developments in this topic. Let's start with the first one. Acute pancreatitis is a systemic inflammatory disorder with rising incidence and high mortality in the severe cases. Organ failure is one of the most important predictors of mortality and severity in this disease, and heart is a common organ involved in the cause of death. The post-discharge mortality in acute pancreatitis is under-investigated, and the recent registry analysis showed that the mortality in the first 90-day period after discharge is almost the same as during hospitalization, and 22.5% of that is because of cardiac failure. That's why there's a need to cover the importance of cardiac-related abnormalities in acute pancreatitis. In recent cohort studies, it has been shown that the severe form of acute pancreatitis is associated with certain cardiac changes like ECG, cardiac laboratory markers, echocardiographic changes, cardiovascular failure, and myocardial dysfunction. The severity can be determined based on the revised Atlanta classification. We can separate 3 categories: mild, moderate, and severe acute pancreatitis, based on the presence and duration of local complications and organ failure. Our aim is to investigate the bidirectional association between cardiac changes and acute pancreatitis outcomes. We have the following clinical questions. What cardiac-related abnormalities are associated with worse outcomes in acute pancreatitis? The population is patients with acute pancreatitis. The factors are certain cardiac-related changes, and the outcomes are hospital and post-discharge mortality, the severity of acute pancreatitis, and length of hospital stay. Our hypothesis is that there are specific cardiac-related abnormalities associated with higher mortality and severity of acute pancreatitis. The second framework contains the same population, and here the factor is the severity of acute pancreatitis, and the outcomes are the certain cardiac changes. We conducted a systematic search in 3 main databases with the following search key. The systematic search yielded around 20,000 articles, and in the end, we could have data extraction from 36 articles, plus an additional 10 found by citation and reference chasing. I will show you my results. For this framework, when the factor is the cardiac-related abnormality, atrial fibrillation and cardiovascular failure could be analyzed with the outcome of mortality. In this first forest plot, the outcome is in-hospital mortality, which is between 3 and 30% in acute pancreatitis. We included 6 studies, observational studies, and the heterogeneity is high because these studies contained all the severity categories in AP, and this is a heterogeneous population in itself. The investigated factor is the presence of atrial fibrillation, and the comparison is the absence of atrial fibrillation. We can see the odds ratio of 2.69. It means that patients in acute pancreatitis with atrial fibrillation have almost 3 times higher odds for mortality in acute pancreatitis. The second version of the framework, we could analyze the factor of the severity of acute pancreatitis for the cardiac outcomes as changes in repolarization, QTc prolongation on ECG, the NT-proBNP level, heart rate, systolic and diastolic blood pressure, and cardiovascular failure. Due to the time limit, I will only present the ECG changes. In this forest plot, the outcome is the odds for repolarization abnormality in the severe versus non-severe acute pancreatitis. We included 3 cohort studies with a low heterogeneity. The factor is severe plus moderately severe acute pancreatitis pulled together. The comparison is mild acute pancreatitis. We can see that patients with severe and moderately severe acute pancreatitis have almost 3 times higher odds for the presence of repolarization abnormalities on ECG. This contains STT abnormalities. In this plot, the outcome is the odds and the presence of QTc prolongation in ECG, which is the corrected QT length for heart rate, and it can lead to fatal ventricular arrhythmias. We included 4 cohort studies in this analysis with a moderate heterogeneity. Here we could also compare the severe and moderately severe acute pancreatitis to the mild acute pancreatitis group. Based on this result, we can say that patients with acute pancreatitis have 2.25 times higher odds for developing QTc prolongations in the severe and moderate category, but this result hasn't reached the statistical significance yet. We need more studies to investigate this outcome. The strength of our study is that this is the first comprehensive analysis in the topic with a high number of included patients. The limitations come from the observational nature of the studies. The time frame, the factors, and the definitions were not precisely the same in these studies. The following conclusions could be drawn: that AP patients with atrial fibrillation face a 3 times increased odds for in-hospital mortality, and those with severe and moderately severe acute pancreatitis are 3 times more likely to develop changes in repolarization on ECG. The implication for practice is that cardiology screening in acute pancreatitis is needed, especially ECG. And the implication for research is further longitudinal studies and more kind of cardiac abnormalities to be investigated, for example, echocardiographic parameters. Currently, in this first project, I'm in the status of manuscript writing. And as I said, in the implication for research in the meta-analysis, we need more longitudinal studies, so we are planning to conduct a prospective observational multicentric clinical study to understand the dynamics of cardiac functions during acute pancreatitis. As I mentioned in the beginning, and the meta showed that there are certain cardiac changes associated with the severity and mortality of acute pancreatitis, but there are no guidelines yet on cardiology screening. That's why we wanted to do this analysis to investigate the bidirectional association between cardiac changes and acute pancreatitis outcomes during and after discharge. So in the first protocol development, we would like to have answers for the following questions. What are the incidences of cardiac-related changes during acute pancreatitis? What is the time dependency of these changes? And what is the association between these cardiac changes and the outcomes of AP? With the population of patients with acute pancreatitis, the factors would be certain cardiac changes. The primary outcome would be the severity of acute pancreatitis, and there are a lot of secondary outcomes like mortality, length of hospitalization, and acute cardiac failure. We hypothesize that there are specific cardiac-related abnormalities during acute pancreatitis. They occur at the beginning of the disease course, and they are associated with worse outcomes in AP. The third project would be the follow-up protocol development for the previous study. It would be a prospective observational multicentric follow-up study for the following question: what are the cardiac-related changes after discharge, and which in-hospital changes are associated with worse post-discharge outcomes for the outcomes of post-discharge overall and cardiac-related mortality and post-discharge cardiac failure hospitalization. The clinical implication could be that in the post-discharge patient management after acute pancreatitis, cardiology screening would be included to see these changes early and with prevention save patients' lives. Here you can see the summary of my ongoing projects regarding cardiac changes in acute pancreatitis. The protocol development is in the status that we had the ETAB meeting recently. I would like to wrap up my presentation with a quote from Albert Einstein: "Life is like riding a bicycle. To keep your balance, you must keep moving." Thank you very much.
Alcohol consumption is a frequent cause of acute pancreatitis, and in alcoholics, the atrial fibrillation, for example, is a lot higher than in the non-alcoholic population. Is there any association between this, probably mechanistic?
I think so. In the meta, we didn't have data about this, but in the protocol, I would definitely include the cause of acute pancreatitis, and we could see if alcohol-related cardiac diseases like dilative cardiomyopathy play a role in this cardiac failure.
So you didn't analyze differently, for example, the biliary type of pancreatitis and the other type of pancreatitis with respect to cardiac mortality.
In the meta, these articles contained all etiologies, so heterogeneous acute pancreatitis population.
I think it would be worse.
Yes.
Sub-analysis in this respect.
I agree, but they don't have the data, unfortunately.
Further questions?
Well done, Vera.
Thank you.
Outstanding presentation. I had a question more like the current clinical practices. Do they do any like cardiology screening for the AP patients or not at all?
Not at all. Maybe ECG at the admission, but that's for all the patients, nothing more.
Okay, thank you.
Thank you.
First question relates to your first project's first part, AF,
Yes.
and an increased mortality. What do you think that patients who have got AF are more likely to end up dead? Is it because they have a more severe inflammation, or is it because they've got some decompensated heart issue? So, in other words, what is the most common direct cause of death in AF plus AP patients? Is it so what drives their increased mortality? Is it the heart or the pancreatic inflammation? That's the question.
I would be the happiest person on earth if I could answer your question, but these studies are poorly conducted and they don't give a cause of death. They say in hospital all cause mortality, so we don't know from the literature. That's why we want to do a proper prospective study to answer this question, because this is really important. If you take into consideration the alcoholic etiology, because atrial fibrillation can be caused by alcohol consumption. Also, if we take into consideration the medication they give for atrial fibrillation, are they anticoagulated, are they not? These are really important informations.
My other question relates to your project and results on the ECG changes, repolarization issues in patients who have got severe or moderate to severe pancreatitis. How much is that down to the fact that these patients are often on intensive care unit receiving a lot of drugs that influence the heart muscle and its electrical activity and the electrolyte disbalance which they have? So in other words, is it because of the inflammation or the medication and the electrolyte issues in these patients?
Yes,
and probably a lot of hormonal changes as well.
Yes, I totally agree, but these are retrospective studies and we don't know the electrolyte level of these patients. I would be really curious about this too, so we will include it in the protocol.